I will be updating you today on two of the abstracts. The first abstract is our phase 2 study of Dasatinib in combination with Venetoclax in patients with newly diagnosed chronic myeloid leukemia. So preclinical studies showed that the combination of the BCL2 inhibitor Venetoclax with a tyrosine kinase inhibitor TKI significantly reduced the percentage or the amount of immature stem cells in mice. Therefore, we designed this phase 2 study to combine Venetoclax with Dasatinib at the dose of 50 milligrams per day, which is the dose that we use at MD Anderson, half the dose of what is approved, the 100 milligram, which is associated with a better safety profile. So in total, we had 65 patients that were enrolled and treated with this combination. For this study, patients received Dasatinib single agent 50 milligrams per day for a total of 3 cycles initially, and from cycle 4 and onwards, Venetoclax was added at 200 milligrams per day continuously in combination with Dasatinib. After the treatment of the first 16 patients, we have noticed that there's an increased risk of neutropenia with this combination. Therefore, we amended first the study to reduce the dose of Venetoclax from every day for 28 days to 14 days per cycle only. And then we introduced another amendment where we further reduced the Venetoclax dose schedule to 100 milligrams per day for 7 days per cycle once patients achieved MR 4.5. After 3 years of the combination, patients continued to receive single agent Dasatinib. Attempting treatment discontinuation and treatment-free remission TFR was considered in patients with a deep molecular response for 5 years or longer. The primary endpoint of our study was the rate of major molecular response by 12 months of the combination or 15 months from the start of therapy. So by 12 months of the combination, 86% of the patients achieved MMR, which is the primary endpoint of the study. 53% achieved MR4 and 45% achieved MR 4.5 or deeper response. We then compared the outcome of patients treated with this combination of Dasatinib and Venetoclax to the outcome that we have observed at MD Anderson historically with single agent Dasatinib alone. Overall, at 1 year, the cumulative rate of major molecular response was similar between both groups, 79%. At 2 years, the rates of molecular responses and complete cytogenetic responses were similar also with both strategies. Now, what about side effects? 2 patients discontinued the study drugs due to adverse events. 1 patient for grade 3 abdominal pain and 1 patient for pleural effusion. In total, we had 5 patients who developed a pleural effusion on this study. Now, the most frequent adverse event observed was neutropenia. However, no episodes of febrile neutropenia was observed. Among the first 16 patients who were treated before the amendment of the study, more than 60% had a grade 1 and 2 neutropenia, and 25% had grade 3 and 4 neutropenia. When we amended the study, the 49 patients who were treated after the amendment was the Venetoclax dose reduction schedule, the grade 1 and 2 and grade 3 and 4 neutropenia were reduced. However, these rates of myelosuppression were higher than what was historically observed with Dasatinib single agent. The survival on the study was very good. We had a median follow-up of 42 months. The 4-year overall survival was 100%. The 4-year transformation-free survival was 100%. The 4-year event-free survival was 96%. And the 4-year failure-free survival was 95%. If we want to summarize our findings, the response rates were not improved with this combination compared to the historical data with the Dasatinib single agent. We had more risk of myelosuppression, which was mitigated using a dose adjustment schedule of Venetoclax. And finally, we need still longer follow-up to better understand and evaluate the impact of the addition of Venetoclax to the rates of durable deep molecular response and treatment-free remission.